ક્લિયરનેટ વાળાને કંઈક બોલવાનું હશે ને?
હા એટલે ઈ કરશે ને મેડમ, હજી રેકોર્ડિંગ ને બધું સ્ટાર્ટ કરશે પછી જ.
Shreyanshi is from ClearNet, I think.
Yeah.
Yes.
Okay.
Shreyanshi is from Clearnet. Supriya is our
Okay, got it.
Yeah.
Yes.
So with
Good
all your permission,
afternoon.
I'm starting the session. Good afternoon and a warm welcome to all the dignitaries present here. I'm Sreushi from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarinet serves as the digital partner for this event hosted by the National Neonatology Forum, Gujarat. And the focus of today's session is case presentation, preterm low birth weight with RDS. So let's begin today's session, for which I would like to invite Dr. Kunal sir to take over. Sir, please proceed with the talk.
Thank you so much, Shreyashi. So today we are continuing with our neonatal Pathshala. Today we are having a case presentation on a preterm baby with RDS. So today with us we have Supriya Chaudhary. She is a resident from Rajkot. Welcome, Supriya. To mentor her is Dr. Manali, and today as an expert we have Dr. Biraj Thakkar with us. So just one information for all those who have not registered for Guj Neocon, we are having next this week itself Guj Neocon at Surat Utopia. So requesting all those who are not registered yet, you can register and join, and we will have a great academic session. So before starting this session, I would request Shwetal ma'am to say a few words.
Thank you, Dr. Kunal. Good afternoon, everyone. This is our case series. We are going ahead with this. For a PG Viva experience, they can get a exam experience, and we have a final year batch who is going to appear for the exam in December, January. So I'm very thankful to Rajkot Medical College who promptly accepted the invitation to present a case. And Dr. Krunal, now you can introduce our mentor as well as the expert faculty.
Good afternoon, everybody. Today's mentor is Dr. Manali Virparia. She's an assistant professor in pediatrics in PDU Medical College, Rajkot since last 4 years. And the presenter for today is Dr. Supriya Chaudhary. She is a third year resident at Medical College, Rajkot. And today's also we have our well-known Dr. Biraj Thakkar. She will be the expert, and she's an in-charge neonatal ICU at Akansa Hospital, Anand, Gujarat. She's been interested in Focus series also. She's been an active member for the NRP, and she's been an EB member of NNF, and she has organized Guj Neocon also. And we'll start the academic session now.
Good afternoon, sir. Good afternoon, everyone.
Good afternoon. You can share your screen, Supriya.
Yes, sir.
Good afternoon, yeah.
Sir, am I visible, sir?
Yes.
Sir, today my name is Dr. Supriya. I'm from third year resident from the PDU Medical College, and my guide is Dr. Palak ma'am and Dr. Manali ma'am. History: baby of XYZ, a 32 plus 6 weeks of gestational age, baby girl, birth weight of 1.2 kg, now 8th day of life, born to a 25 years old G2 gravida to para 1 live 1 mother, non-consanguineous marriage, parents residing at the Rajkot. Baby was born on 18 September 24 at 6:51 a.m. at Janana Hospital, Rajkot. Mother LMP was on 1/2/24 and ED was on 8th of November 24. Presenting complaint, baby was admitted in the NICU for respiratory distress, preterm and low birth weight. Antenatal history: first trimester pregnancy was confirmed by UPT kit and had history of fever and vomiting, which was relieved by medication paracetamol, not associated with any rash, and folic acid was taken, and one DT injection was given at 3rd month, and no history of any medical illness or drug intake except for paracetamol, and no history of any radiation exposure. And dating scan was done, it is of normal, and EDD was at that time, lady scan EDD was confirmed of 8 November 2024. In second trimester, quickening felt at 5th month, and second dose of TT injection was given in the 4th month, and 5th month quickening felt in the 5th month. Anomaly scan was normal, and iron and folic acid supplements and calcium supplements were taken. No history of any headache or vomiting or any gestational diabetes history, sir. Third trimester, in 7th month of gestation, mother had complaint of headache, vomiting, and pedal edema. And on examination, blood pressure is of 140 by 80 Hg as diagnosed as pregnancy-induced hypertension. Started on labetalol tablets and Nicardia tablets. And at that time, third trimester, growth scan was normal and no history of any decreased fetal activity. On 32 plus 6 weeks of gestation, around 9 p.m., mother had headache, which is of severe throbbing in nature, associated with the facial and pedal edema, having high blood pressure readings. And at the time, patient has been referred to government hospital, and injection MGS were given in view of impending eclampsia. No history of any leaking or bleeding PV. Before referral to the government hospital, 1 dose of betamethasone given 10 hours before the delivery in private hospital. And delivery room or intrapartum details. Our baby was delivered by emergency C-section due to impending eclampsia in the mother at 32 plus 6 weeks of gestation and birth weight of 1.2 kg at 18th November 2024, each of time 6:51 a.m. It's cephalic presentation. Baby cried immediately after birth, and baby had given routine preterm care, dry and position, and routine preterm care, low birth weight care was given. And injection vitamin K 1 mg IM stat was given. Liker was not false spelling, and Apgar score at 1 minute is 5 by 10, and at 5 minutes is 7 by 10. And postnatal history, baby was admitted in the NICU due to respiratory distress and grunting. And at that time, SAS score was 5 by 10. Started on CPAP support. Baby was started on CPAP support of PEEP of 5 with FiO2 of 30%, and which heart rate at the time is 138 and SpO2 is of 94%. And we started with the empirical antibiotics and partial parenteral nutrition. We have started at 5 hours of life. We have started with the minimal feeding, enteral feeding, and at 16 hours of life, gradually increased the enteral feeding and decreased FiO2 to 21%. At that time, baby was already past the meconium. And at 24 hours of life, baby shifted to O2 prawns and gradually increased RTF. And at 34 hours of life, baby was given OFO2 trial also and shifted to full enteral feed, and urine passed at 36 hours of life. At 80 hours of life, at 54 hours of life, TCB is of 8, monitored for physiological jaundice, and 80 hours of life, TCB of 16 started on phototherapy. And septic stain was negative and stopped antibiotics after 5 days. And at present, baby is on full enteral feeds with supplements, and grandmother is giving KMC for 10 to 12 hours. Family history, no significant family history. And nutritional history, we gradually on day 3, patient was shifted to full enteral feeding. At the time, 110 ml per kg per day, according to that calories of 88 kilocalories per kg per day, and 1.1 is the weight of the baby. And gradually, patient till day 4, patient is having formula feed, and from day 5, mother had decreased secretions, and we have started on supplements from the mother, and mother is also on NBM. And till from day 5, mother is can able to express the breast milk, and we have started on the child on the express breast milk from day 5, 140 ml per kg per day and 90 kilocalories per kg per day. And day 7, we started on the full RT feeding, and with day 7, we started on the HMF sachet with calcium and vitamin D supplements. Anthropometry. Patient at the time of admission, patient had 1.2 kg weight and length of 38 centimeters, head circumference of 28 centimeters, and 34 weeker. And now the patient is of 34 weeker and weight of 1.1 kg and length of 38.5 centimeters and head circumference of 28 centimeters, which was plotted in the growth chart, sir. Investigation HPs of 12.2 and WBs of 5,200 and platelets of 222,000 and CRPs of negative sodium and potassium and creatinine levels were normal. Chest X-ray bilateral equal expansion of lung, no haziness was noticed at the time of admission. in NICU, blood CS negative, and USG cranial ultrasound on third day of life is normal, and screening 2D echo was normal. Sir. Clinical examination, temperature vitals, temperature is of 36.8 degrees Celsius, and heart rate is of 142 by a minute, no radio, no radiofemoral delay, respiratory rate of 38 per minute, CRT of less than 3 seconds. On head-to-toe examination, no abnormalities were detected, and PF is fingertip open, and EF is of 2.2 centimeters at the at the level of the bone edges, and gestational age assessment with the new Ballard scoring, modified Ballard scoring, and it is of coming under 34 weeker. Neonatal reflexes, Morose reflexes, there is extension and abduction of the upper extremities is there, and there is no anterior flexion and adduction, and palmar grasp and plantar grasp are present, and rooting reflex is absent. So. And systemic examination, posture is at rest, is slight flexion at the hip and knee, and upper limb is in extension, tone is more in the lower limbs compared to the upper limbs. Respiratory system, bilateral air entry is equal, no added sounds, and cardiac system, no murmur or no radial delay. And pericardial pulsations will be visible at the 5th intercostal space. Abdominal system, per abdomen soft, and liver span is of 4.5 centimeters. No hepatosplenomegaly. And in summary, baby of XYZ, a 32 plus 6 weeks of gestational age with birth weight of 1.2 kgs, born by emergency C-section due to impending eclampsia in mother, given 1 dose of bectamidazole 9 hours 50 minutes 10 hours before delivery, and baby admitted in NICU for respiratory distress and preterm, low birth weight. Now baby having post-gestation age of 34 weeks and weight of 1.1 kg on rice tube feeding. Supplements were added from 7th day of admissions. Final diagnosis of preterm, 32 plus 6 weeker, HGA 1.2 kg, very low birth weight, and RDS, sir.
So, okay, Supriya, it was nice presentation, but can we go back to first or second slides regarding LMP?
Yes, ma'am.
So LMP you mentioned was 1 to 24.
Actually, it was incorrect, ma'am, but based on the history from the mother, she get the recollection from the date only, ma'am.
So then, like, how did you calculate the gestational age? Like, was that from the EDD in the back direction? How
Ma'am?
many days early?
How many days? 2 months early, ma'am. That 8 weeks early.
8 weeks early.
Yes, ma'am.
Okay. Then second is folic acid tablet. Mother had received folic acid tablet. So any further detailed history regarding from when the folic acid tablets had been started?
Just we asked for the folic acid. They are actually follow-upping in the private hospital, ma'am. They mentioned about folic acid was started after diagnosing pregnancy at around 2nd month, ma'am.
Okay. And ideally folic acid कब शुरू करना चाहिए?
Actually, preconceptionally 3 months before.
Yeah.
1
What
month
is the
prior.
role of folic acid?
1 month prior.
Okay. Then what is the dose for iron and folic acid supplementations in regular ANC?
Ma'am, folic acid supplementation in normally 400 micrograms, like 0.4 per mg in regular pregnancy. If any neural tube defects is suggested, already previous pregnancies of any neural tube defects in the babies, and we'll give 4 mg, ma'am.
Then you mentioned something about the magnesium sulfate was started to mother. For preeclampsia,
ma'am.
Maxel dose was given. That's
Yes,
what
ma'am,
you
Maxel
mentioned.
dose was given.
Yeah. So how much Maxel was given? So like if you just put the detail, then there won't be any questions arising. So whenever you're presenting a history, so how much Maxel was given?
Yes, ma'am, it was around 1 gram, ma'am.
Okay, and here it was for the eclampsia,
Yes,
preeclampsia.
ma'am. Yes, ma'am.
And what is the other indication for magnesium sulfate and preterm newborn?
In
Are you aware
preterm,
about any role of magnesium sulfate for a preterm given to mother? Antenatal Maxel.
Antenatal maximum.
Have you heard anything regarding CP, Maxilf and CP for prevention of cerebral palsy for preterm?
Yes, ma'am. Yes, ma'am.
What is the cutoff gestational age before which it is to be considered for prevention of the CP for antenatal mother? Go through it. It is a hot topic, magnesium sulfate, antenatal Maxilf, right?
Okay,
So
ma'am.
it is to be given in continuous drip. Usually there are different recommendations, 31 to 32 weeks before. So here it is not exactly de-indicated, okay? Before 32 weeks of the pregnancy, Maxilf can be considered to prevent the CP in the newborn.
Yes, ma'am.
Okay, then steroid. You said that betamethasone 1 dose given. So can you tell me that what is the adequate steroid coverage where you expect, okay, fine, the baby has been antenatal steroid covered?
At least 24 hours has to be there plus steroid coverage, ma'am.
But 24 hours should have been passed for 1 dose of betamethasone. Like here, the mother has received 1 dose of betamethasone 10 hours
Okay.
before delivery. So if the mother would have received the betamethasone 1 dose 24 hours before delivery, so can we consider it as an adequate
No, ma'am, it
steroid?
has to be like 2 doses has to complete one course.
Complete course, yeah. So which steroid is preferable? Is it a betamethasone or a dexamethasone?
Ma'am, actually, dexamethasone is preferable, recommended. Look, we can give betamethasone, like you say, is like time efficient. We can give in 24 hours, like 2 doses we can give. But in dexamethasone, we have to like 4 doses we have to give, ma'am.
So that is why the betamethasone is recommended,
Yes, ma'am.
because it's a long acting. Are you aware about which salt is there? Whatever studies has been done and
Yes, ma'am.
whatever
Actually,
they have got.
betamethasone salt is not available. So normally preferred will be like dexamethasone and phosphate and all.
So betamethasone is better, but the salt which has been studied and recommended is not available in India. Okay.
Yes,
So
ma'am.
then it is having no added advantage over the dexamethasone. So one
Dexamethasone.
can give a dexamethasone even, okay, which is a cheaper alternative and readily available.
Yes, ma'am.
Fine. Okay. So the complete course should have been finished before 24 hours. Then only you can consider it as an adequate steroid coverage.
Yes.
Then I'm not sure. Did you mention anything regarding cord clamping at the time of resuscitation? The
Actually,
baby
not.
delivered at your hospital, right?
Yes, ma'am.
Okay. So the attending pediatrician, whosoever would have attended the delivery, has she or he mentioned about cord clamping? What is recommendation?
Actually, delayed cord clamping is recommended recent time, ma'am.
Yeah, so you should discuss with your gynecologist, and the cord clamping is to be delayed. How much delay is to be done? What is the advantage?
More than 1 minute, actually, it will give extra hemoglobin or extra blood volume to the baby, ma'am.
So prevent anemia.
Anemia.
Okay, so is it more than 1 minute? Is it less than 1 minute, or is it for 1 minute? What is
It is for 1
recommendation?
minute.
I know there are
It is
various
for 1
studies.
minute.
Studies has been done for 30 seconds, even for 3 minutes. So what is the recommendation?
It's for 1 minute, ma'am.
At least, yeah, 30 seconds to 1 minute,
1
unless
minute.
it is contraindicated. So can you tell me what are the contraindication of delayed cord clamping?
Ma'am, already child had any birth asphyxia or not able to not read immediately after birth and child in resuscitation during the neonatal procedure, then we will not delay for the cord clamping, ma'am.
Will not wait for the cord. Yeah. So any other contraindication?
Any
What
RH
RH?
incompatibility?
Is it a contraindication or not? So there is no other contraindication. RH incompatibility is not a contraindication for delayed cord clamping. Okay, previously it was considered to be, but then later and latest recommendation is it is not the contraindication for going for the delayed cord clamping. Only contraindication for delayed cord clamping is if child is in need of active resuscitation. Okay. So ideally, you should follow the delayed cord clamping, and while presenting, definitely you should mention about that, whether it has been followed or not. Okay. Then the baby delivery. Hana, they come to that slide when the baby delivered. So delivery room here you had you should add on like delayed cord clamping wala point. Then again, then antibiotic started. That is what you have just said. The time of like some management inside the NICU. So child had respiratory distress and grunting, and you mentioned probably about the scoring system. Yeah, SAS score was 5/10.
Yes, ma'am.
Started on CPAP support with PIP of 5 and FiO2 of 30%. So, what is ideal respiratory support, which is to be started for 32-weeker baby having a respiratory distress? And how do you decide whether to start with the CPAP, whether to start with NIMV, whether to start with the HFNC? What are the recommendation and what are the evidence?
According to in 32 weeker, we'll go with the CPAP. According to the SAS score, ma'am, we'll go initially prefer with the if you're having any grunting with the stethoscope, we'll start with the CPAP support, ma'am. And if a patient is having this severe distress and all, and if you need, we'll look for the X-ray, and patient needs surfactant, and if your requirement is more than 40, and gradually there is increase in the PEEP also, then we'll go for the insure method, ma'am, surfactant, and we'll go with the non-invasive ventilation, ma'am. And if it is more than 7, score is of more than 7, we'll intubate the patient, ma'am, for the due to respiratory distress.
Okay, that's great. And any role of HFNC when 32 plus 6 weeker
No,
baby is there?
no, it's not. It's not recommended. Actually, it will cause treatment failure only again after that.
Okay, here the patient is SGA, then that's fine. In this case, whenever like whosoever clinician is there on duty has decided to start with the CPAP support, that is absolutely the fine decisions. But ideally, if you just look at the evidences, then more than 32 weeker babies, evidences are enough to start HFNC as a primary care support. Okay, I'm not saying that there won't be any failure. Okay, there might be a failure, but then it is not that much significant. So, but definitely those who are less than 32 weeker, one should start with CPAP as a primary support. HFNC as a primary modality of treatment is definitely has shown enough evidence to be failed if it has been started for less than 32 weeker baby. So yours is kind of a gray zone gestational age, 32 plus 6, but again, the same time you're having a SGA baby.
Yes,
so the
ma'am.
decision is okay. Fine. And regarding the insure you mentioned, have you ever heard the procedure named Lisa?
Yes, ma'am.
So what is Lisa?
Actually, we do not intubate, ma'am. Just we put the trials tube like a thin catheter into the endotracheal tube, tracheal, and we'll give surfactant delivery via that, ma'am.
Yeah. So what is the full form? Less invasive.
There's you surfactant administration.
Okay. Fine. So again, there is a big debate whether it's Lisa or Insure, and there are many evidences. So, but here, if you are comfortable in Insure, then definitely you can go ahead with the Insure. Like, it's not like even if you're not comfortable with the Lisa, then go ahead with the Lisa. It's not like that. You should be first master in the technique, and then only you should go ahead. Okay, fine. So you have started mentioned somewhere regarding starting off of the antibiotics. I just wanted to see that. Day 5th, you started minimal enteral feeding. Till 5 days, the child was NBM, right?
5 hours of life, ma'am.
5 hours of life, you started minimal enteral feeding. So here
Yes,
the
ma'am.
child is SGA. Did you mention anything about the antenatal Dopplers?
Actually, it was not. Actually, I checked for that, ma'am. They were following the private and they have not done any antenatal Doppler, ma'am.
Because when the child is SGA, so your main concern is there might be alteration in the Doppler, and in that case, shall we go ahead about the feeding or not? That is the biggest query, right? So, what is the main problem when you start early feeding for those who are having an altered antenatal Doppler? What is your concern?
Ma'am, it will be like more feeding intolerance will be there. It is like absent endostolic flow. There will be like any mesenteric flow will be decreased, ma'am.
Hmm.
So that's why there will be more staying of food particles in the gut, and it will cause more feed intolerance and more chances of NEC will be there in the HGA babies, ma'am.
Yeah. So then 16 hours of life, you have gradually increased the enterofeeding and decreased FiO2 to 21%. Baby passed meconium. Okay, after that, go ahead. 24 shifted to O2 prong, 34 hours given off oxygen trial and shifted to full enteral feeding. So the child was on full enteral feeding directly from 34 hours of life, right? Almost 1.5 days.
Yes, ma'am.
Okay. And you mentioned, septic screen was negative and stopped antibiotic after 5 days. So you started empirical antibiotic, prophylactic antibiotic, right?
Yes, ma'am.
And when did you send the septic screen? The same day at the time of admission itself or later?
At the time of admission, actually, we send blood CS, ma'am. And
Okay.
after that, 48 hours, we'll do CRP, ma'am. And
Okay.
blood CS is also negative and CRP is also negative. So after that, we plan for stopping antibiotics after that, ma'am.
Yeah, so I think that thing should come at the time of presentation, because here it's directly stopping of the antibiotic has been mentioned. That is really good to stop it early. But even while starting of the antibiotic, you should follow this antibiotic storage tip. That is the same thing which you are doing. Like, take a blood culture, start with the antibiotic because child was SGA, because there was a respiratory symptoms. So the child was might be fulfilling into the criteria for starting a prophylactic antibiotic for early onset sepsis. That you can consider the symptomatic patients, right? In
Yes,
that case, collect the blood culture and then start with the antibiotics. And as soon as the culture is negative, rather than screen negative here, if culture is negative, ideally you should stop the antibiotics. So that is what the ideal thing, right?
yes.
Fine. So then you stop the antibiotic from 5th day onwards and present a full enteral feeding with the supplements. So can you mention which kind of supplements?
Ma'am, actually, we started with the calcium, phosphorus syrup, ma'am. And we have started on vitamin D3
Hmm.
and we started on HMF, ma'am.
Okay. And when do you start iron supplementation?
Actually, after 7 days or 14, if antibiotics are there, we'll plan after 14 days, ma'am. Now we plan to start iron folic acid, iron supplements, ma'am.
No, is it to be started from 7th day or 14th day? I
14th,
couldn't
we
get
have to start from the 14th day.
14th day.
Hmm.
Whether with the antibiotic or without antibiotic. In both the cases, it is to be started on 14th day.
Yes, ma'am.
Hmm?
Yes, ma'am. I thought.
Yeah, it is to be started after 14 days only, right? Or else the child is on whichever is later, like if 70% feeding or 14th day. If your child is on the full feeding from 36 hours of life, then you started on the 14th day. If your child would have not been on the feeding, like even on 14th day, if child is on hardly 30% of feed, then definitely you are not going to start with the iron supplementation. So 70% of the feed or 14th day of life, whichever is later, you'll be starting with the iron supplementation. Okay, and HMF you mentioned, right? Which HMF sachets are you using? Because there are various HMF sachets available. And then what are the contents? And with HMF, would you like to consider giving iron or not?
Ma'am, we are using pre-fortified, pre-non HMF, ma'am.
Pre-nan. So have you checked what does the contain of pre-nan? Because what I am using, I have checked the content. I am not sure about the pre-nan content. Must have been there in one of my presentation. Did you check?
Ma'am, I
If you
checked
have a
both.
pre-nan sachet over there, are you in the unit?
No, I'm in my room.
You are at the unit, right?
Yes, I'm in the room, ma'am, actually.
So just ask someone to get the pre-nan sachet from patient के bedside पे ही होगा ना if you're
Yeah,
using pre.
ma'am.
So
Actually, I
ask
have taken
someone.
the photo, ma'am. I have photo of
So
that.
then just have you put the photograph in the presentation? Did I miss it?
No, ma'am, I have photograph in my phone.
So just go and read the presentation.
Actually, each 1 gram contains energy value of 3.5 calories with protein of 0.26 and vitamin C, vitamin A will be there, and folic acid will be there. Folic acid of 20 micrograms, vitamin A of 60 micrograms, and B1 to B1, B2, B6 will be there. And vitamin K is also there 1.1 ma'am. Vitamin D is of 3.32 ma'am. B12 is also there of light quantity 0.05 micrograms. Along with phosphorus, chloride, and biotin and zinc is also there, ma'am, 40 micrograms, and iron supplement is also there, along with manganese and copper, ma'am.
So there is iron, there is protein. How much protein you mentioned?
0.275 gram, ma'am.
0.275 gram in 1 gram sachet.
gram.
And
Yes,
calories is 3.5 kilocalories.
Yes, ma'am.
So how many sachets are you adding in a day? And this 1 gram is for 50 ml or 25 ml? How are you
1
making
gram
the
is for
feed?
25 ml, ma'am.
25 ml and you are adding 1 sachet. So in
One
each
sachet
25
every
ml,
time.
you are adding 1 sachet,
Yes,
right?
ma'am. Yes, ma'am.
So in entire day, how many sachets goes?
In the entire day, we'll give in 12 sachets, ma'am.
25 ml per feed जा रहा है उसको? Every
25 ml feed, हाँ ma'am. अभी
1.1 kg का बचता है.
160 से, हाँ ma'am. 16
150.
ml feed जा रहा है मैम. तो हम वन सैचेट में उसमें
Child is how many days old now? Today is what day of life?
34 week है मैम. 7th day, 8th day मैम.
8th day of life. So 180 से feed जा रहा है?
170 से जा रहा है मैम.
Okay, 170 से feed जा रहा है into 1.2 was the birth weight. When do you consider birth weight and when do you consider the current weight to calculate the feed amount?
Yes ma'am.
So divide by 12 if I make it, then 17 ml ideally should be the aliquot. So
Yes,
if
ma'am.
child is receiving 17 ml every 2 hourly, child is receiving 200 ml of milk only in an entire day, then there should be 8 HMF sachet, not the 12.
12. 8
Yeah, so while you're presenting any preterm case, you should just look for the nutrition, whatever supplements are being added, how much extra calorie child is receiving. You have mentioned the calories, but किसमें से कितनी जा रही है? पूरे दिन में 12 HMF ही नहीं जा रहा है, 8 HMF जा रहा है. If in case if you are adding in each and every, sometimes if the child is tolerating feeding well, is on full feeding, then you may not even require to add the HMF. What is the recommendation when the HMF are to be added?
In less than 1500, 1.5 kg ma'am. And gradually if weight gain is not there and not able to gain the birth weight also, then we plan to add a HMF ma'am. But it's already 1.2 kg, less than 1.5 kg, so we added HMF ma'am.
Yeah, so if the child is less than 1.5 kg, जो भी आप बोल रहे हो, या 2.5 kg I would say, but if child is not putting on weight, then you add the HMF sachet,
Yes, ma'am.
right? If child is not putting on weight, in that case you add the HMF sachet. It may happen that you just increase the feed maximum amount, आप 180 तक feed पे भी पहुंचे नहीं हो. If you just give the proper amount of the feeding, are you worried about the BPD in this child? While your feed is on lower side, you can even still go higher up on the feeding if there is no reflux and no other issues. So you can just give the calories from the feed only, and if child is putting on weight on the same, there might even not be the need of the HMF sachet. Again, it's a debate with HMF, without HMF, whether it is to be added or not, but the final recommendation still now is that if there is no weight gain, then HMF can be added. Okay.
Okay.
Again, iron supplementations. How much iron is being added? So you should calculate that. So iron, like the HMF sachet Reptacos ka jo which I am using is like this. It has ions, enough amount of the iron. So then on for preterm there is only need of 2 milligram per kg, not the 4, because already उसमें से आपको extra 2.5 gram तो मिल ही जाता है iron. If you just calculate the entire day need and entire HMF you are adding. So that exercise you need to do.
Okay.
Okay, fine. There are some chat questions regarding HMF, I guess. Let me go through it. What are the contents of HMF? We discussed which HMF are using. That is what you discussed. How much of it added and quantity, that has also been discussed. Then regarding calcium, how much calcium are you adding? 6 sachet per day if receiving 150 ml per kg. Yeah, so yours is 8 sachet जा रहा है. ठीक है. So how much calcium are you adding?
We are adding calcium of actually in HMF ma'am or normal supplements.
HMF में भी calcium है. So do you actually require to add the normal supplementations, the extra supplementations of calcium?
Actually, इसमें 25 mg ma'am. We are adding in 8 feeds also.
Hmm.
As it is not required ma'am.
मिल इक्विवेलेंट कितना है? 25 मिलीग्राम है
200 mg ma'am.
You just check it out. You need to go through it. Probably it might not be even vitamin D sometimes is not required when you are giving a proper HMF.
25 milligrams is available in the 1 gram sachet ma'am. So it's like 200 mg is available.
8 sessions. Fine. Okay. और what is your recommendation when the HMH is to be added? एक तो आप है कि feeding वजन नहीं बढ़ रहा है तो ऐड करोगे. Then the feeding like is it a 30 ml, 50 ml, 70 ml कितने feed पे ऐड करोगे कुछ? तो 70% feed पे पहुंचता है उसके बाद you can consider even if it's required. Okay, if child is putting on weight then there is no need of putting the HMF. Okay. Fine. Then you mentioned something head circumference was static in last 8 days. Is it so?
Yes, ma'am, 28 centimeters is it.
There is no gain in head circumference, or that might be subjective error, do you think?
Might be, ma'am, but I've actually, it was taken initially and I've taken after that. It was of same, ma'am.
Fine. Then you also mentioned regarding screening 2D echo. What is screening 2D echo? Why it was done?
It was like preterm, ma'am, we have to look for any PD and all.
Sorry?
Ma'am, like screening only we have done 2D echo, ma'am. In 1.2 kg, look for any PDA.
So is it your routine protocol, unit protocol to get the 2D echo done for each and every preterm infant? Is it so? That's how you just ended up getting it done?
It's not actually, ma'am. We'll first look for the clinical examination and if it is requiring and we'll go for the 2D echo.
So because what I could see from your history is your child was on at the 36 hour was on complete full feeding, was off oxygen probably by that time. So
Yes,
then why the child had undergone the 2D echocardiography? You know?
Yes, ma'am.
Just go through the proper recommendations. So not only like echo is in fashion, so it is to be done for each and every infant or preterm infants. If it is indicated, then definitely yes. The people are forgetting to get the X-ray done and get the echo done before. Yeah. ऐसा हो रहा है. Okay, can you read out the X-ray?
X-ray, ma'am, it is not rotated, it's clavicle, so midla and the trachea is not shifted and lung bilateral lung expansion is there, ma'am, and it is of it is expanding in line intercostal spaces and no haziness and hard borders or in shape, ma'am. There is no any cardiomegaly is there, ma'am. And
So like is 9 intercostal spaces normal?
intercostal spaces is actually normal.
You said 9 intercostal spaces, right? 1, 2, 3, 4, 5, 6, 7, 8, 9. So is it normal or is it hyperinflated?
Hyperinflation.
So what do you expect if it's a HMD? What diagnosis did you mention? Did you say HMD, right?
HMD. A high RDS, ma'am.
Is
HMD.
it a HMD?
No.
You think from the X-ray,
No.
do you think it's HMD?
No, ma'am.
It could be TTN, right?
Yes, ma'am.
Some aspiration also, some liquor aspiration also. That
Liquor
might
aspiration.
also lead to some amount of the need of oxygen and the respiratory support. Okay, fine. So this is up to what you presented. Then what is next? On head examination, okay, okay. Are you going to show the examination on bedside, or are we going to discuss on PPT only?
PPT.
No, PPT only? Okay, fine. Fine, go ahead then. General examination के बाद आगे you mentioned even the systemic examination, everything was
Yes,
brief.
ma'am.
Rotting was absent. Why?
No?
Why the rotting reflux was absent?
It was not present.
Hmm. Okay, fine, go ahead. After reflexes, systemic examination. Okay. Done. Final diagnosis is preterm 32-weeker SGA, VLVW, and RDS. Fine. How are you going to manage this child further?
Ma'am, we'll monitor for the weight and we actually gradually 34 weeks and we gradually increase the spoon feeding, cup feeding and all. And we advise for the mother to give the breastfeeding and spoon feeding, and we gradually increase with the breastfeeding also, ma'am. And after that, we give KMC and we look for the supplementation also, ma'am. If it is coming under in HMF, we don't need to add any other supplementation. And we look for the anemia and all, if look for any complications, ma'am.
Okay. When did you start KMC? Have you started or have you not started?
Actually, we started, ma'am, KMC.
Fine. So you started KMC. How long the mother is receiving KMC?
Actually, till 4 days of life, my grandmother is giving the KMC, ma'am.
You
After that,
mentioned. Yeah.
mother having stitches and all, and having BP higher readings after that also. So they're keeping that mother in the ICU for 2 days, and after that shifted to ward. And grandmother is there with the baby, ma'am, and giving KMC for 10 hours, ma'am.
Okay. So you mentioned about screening echo. Did you mention about screening ultrasound, head ultrasound?
It's mentioned, ma'am. On 3rd day we have done screening ultrasound, ma'am.
Okay. So what is the screening protocol for ultrasound ideally? Which babies are to be screened for, and then what time they are to be screened for?
Actually, we are screened for this NSU high risk babies, ma'am. Like birth asphyxia babies, we have to look for any and preterm babies, low birth weight, very low birth weight.
So what is the cutoff gestation below which you will be planning for the USG screening, and above which you won't be planning for USG screening?
Ma'am, around 34,
Just
34
mention your unit protocol. That's fine. Different unit may have a different cutoff. That's okay. What is your unit protocol?
34 to 36 weeker will in less than 36 weeker will do a 3rd day ultrasound, ma'am, USGA. And after that, if it is of abnormal, we'll screening follow up after every weekly, ma'am.
Every weekly.
Yes, ma'am.
Till you discharge the child?
Till after and follow up also we'll do, ma'am. Actually, if it is any abnormal,
So
is
till
there
what
and
gestational age would you like to consider doing a head ultrasound weekly basis? So you should have an idea about the USG screening protocol, okay, for IVH in case of IVH, and then PVL2 in case of preterm infants. Those who are less than 34 weeker, those who are on the ventilator, and this sick infants, what you mentioned, everyone should undergo USG ultrasound, okay?
Yes,
Day 3 तक 95% of the IVH would present till
Yeah,
day 3 of
until
life. So that is why on day 3rd day, one ultrasound, then on 7th day, another ultrasound. Okay, at 36 weeks of life, ideally there should be one again on 21st day. But in case cost is the issue in India, if we are avoiding an initial 2 ultrasounds are normal, you can directly plan something at 36 weeks, and that ultrasound is to rule out the PVL. It's somewhere around 1 to 1.5 months. Full term बच्चा होता है तब एक ultrasound आपने चाहिए, and till that time if it is normal then you can stop getting it done, but not at least once a weekly, till 36 weeks or 40 weeks तक आप weekly ultrasound कराओगे तो costing कितना बढ़ जाएगा इंडिया में.
Okay.
Fine. So that was regarding USG screening. Any other screening would you like to plan for this baby?
We'll look for the bone profile screen for metabolic bone disease, ma'am.
Yes. Age कब कराओगे, क्या क्या कराओगे?
Ma'am, we'll look after 14 days, 20 days after that, ma'am. We'll look for any hypocalcemia or hypophosphatemia, and we have to supplement according to that, ma'am.
Yeah, after 3rd completed week, calcium, phosphorus, alkaline phosphatase, right?
Alkaline phosphatase.
Then anything else? Bone scan के अलावा एक और रह गया कुछ? 2 रह गए.
ROP.
आँख कान रह गए, आँख कान बता दो. आरोपी बता दो. और कुछ रह गया?
हाँ मैम.
रह गया.
ROP की we 34 weeker we will do after 21 days, ma'am, 21 or 28 days. And if it is like before 32 weeker, we'll preferably we'll do it on the 21 day, ma'am. 21st day.
Before 32 weeker, you will be doing on 21st day.
21st
So
day.
matlab, if my child is of 25 weeks, I should be getting the ROP done on 29th week?
No, ma'am, after 4 weeks only. After 2 weeks, matlab 21 day of life.
21 day of life for a 25 week newborn is 26, 27, and 28th week completed. Corrected gestational age of 28 weeks. So you should be aware about ROP guidelines too, कि उसको 31 week पे आपने करना है. Those who are more than 31 weeker should be getting it done on 3rd week of life.
3rd week.
Less than 31 weeker, 25, 26 के ideally 31 weeks पे करते हैं. That is what the Cloharty mentions their protocol. Again, different hospitals may have some variation from the protocols. और आजकल तो उसके medical legal issues इतने होते हैं, so you should be more careful. फाइन. आरोपी. देन एक और क्या रह गया? आंख, फिर कान बताया मैंने आपको. क्या करोगे उस हियरिंग के लिए?
OA we'll do, ma'am.
Will you be doing OA for this child or anything else would you like to go for? What are the what neonatal hearing screening tests are to be done? Options क्या क्या available है? Which options are available?
वो ही है मैम.
दूसरा क्या है बताओ?
Not ma'am.
बेरा है या नहीं है?
बेरा
है ना? ऑटोमेटेड बेरा होता है ना?
Yes, ma'am.
ABR.
ABR.
So ideally, an ICU graduate should undergo ABR. Otherwise, any full-term infant should undergo OA. That is okay. Okay. But if you are not getting anything done, then it's okay to get the OA done. But ideally, for an ICU graduate preemies, ABR is better option. What is the difference between OA and ABR? पढ़ लेना. Okay. Fine. Any other screening test for any newborn?
Screening test thyroid profile.
Okay. ब्लड स्पॉट में जो आएगा क्या क्या आता है उसमें? थायराइड प्रोफाइल, देन
ब्लड स्पॉट, TMS, टैंडम मास स्पेक्ट्रोमेट्री.
सो एक ब्लड स्पॉट ले लिया आपने, एक हियरिंग करा लिया आपने, ठीक है, एक आपने आरोपी करा लिया, और कुछ रहा? आपने तो पूरा इको ही स्क्रीन कर लिया है. व्हाट इज अदर स्क्रीनिंग टेस्ट? for congenital heart disease. You should be aware about the newborn screening test, pulse oximetry screening test. A pulse
Yes, ma'am.
oximetry screening test, if you find something, then you should go for the echo. So we have directly done the echo considering the child is preterm and whatever to rule out the period. That's a different thing. But ideally, for otherwise any newborn, if there is a pulse oximetry screening test, if positive, then only you should be going for the echo, confirmatory echo. Okay, fine. Is this the end or is there anything else you would be presenting? Done, na?
Yes,
Yes.
ma'am.
Okay. Kunal, are we
Yes.
okay? Any other questions, queries,
Uh,
discussion points?
no. Thank you so much, Biraj ma'am, for the excellent discussion. You have gone into much detail and took out all the points which were missing also. So thank you so much. Shwetal ma'am, would you like to say something?
Yes, it was really excellent discussion. Just one suggestion I want to say that we should look for EUGR in from the first week onwards. Why is it happening? Where the
Yes,
baby is losing the weight? Because what your anthropometry have mentioned,
yes,
Supriya,
ma'am.
so the birth weight was 1.2, right? And right, what is the today's day of life?
Day 8 of life.
Day 8 of life, no? So this is the right time you pick up and your present weight is 1.1. Whereas it was very good FBNC protocol you have followed that your baby was on feed from, I think, 5th hour of life. And by 36 hours, you are on full feeds.
Yes, ma'am.
You have already added your HMF. So and there is no other morbidity. Baby is off ventilation.
Yes, ma'am.
So you can look into the matter where your baby is losing the weight. The first possibility in the preterm is a hypothermia, where they are losing the weight. In spite of giving 10 to 12 hours PM, is it an hypothermia or you are just giving a foam instead of hind? So you can look at Dr. Manali madam, just look into this matter.
Yes,
So
yes,
that
ma'am.
100-gram weight to catch it will be very difficult later on. And your head circumference also, as well as your length. This will
Yes, ma'am.
further affect neurocognition. Okay. Otherwise, very well managed case. Okay, congratulations.
Thank you, ma'am.
So Kunal, we can widen up.
Yeah, thank you so much, Supriya, for the excellent case presentation. Thank you, Manali ma'am, for mentoring her. Thank you so much, Biraj, for the excellent discussion you had brought up. Thank you, Krunal, for excellently moderating the session. Thank you, Sheila ma'am, that you are there with us till the end. Thank you so much. Thank you all the participants, and don't forget to register for the Gujni-Ocon. Thank you, Shreyashi, for the seamless experience by the ClearNet. Thank you all.
Thank you,
Shreyashi, you
sir.
can wind up. Yeah.
Thanks for the invitation and bye.
Thank you.
You all
Thank
at Surat.
Yes, we'll meet
Yeah.
there.
We'll meet up
Thank
there.
you.
Yeah. Bye bye.
Bye.
Thank you so much, everyone, for giving us the opportunity to host the session. Thank you.
Thank
Have a good day.
Thank you.
Thank you.
you.